درود خدمت همه شما بینندگان عزیز تلویزیون جهانی کانال 1 با برنامه دیگه ای از طلوع خدمت شما هستیم با بهترین تازه ترین اطلاعات پزشکی. مهمان این هفته ما اکزیکیتیو دیرکتور دپارتمان سایکیاتری دانشگاه هاروارد هستن، آقای دکتر جری روزنبام. ما خیلی خوششانس هستیم که ایشون رو داریم که در مورد یک بیماری خیلی شایع به اسم اضطراب یا انگزایتی برای ما بگن. Dr. Rosenbaum, I'm so thrilled for this interview. I greatly appreciate accepting my invitation. Thank you so much.
Hi, Nagar. It's good to see you again. It's good to be with you. I'm happy to talk to you today.
Thank you so much. I'm so honored for this interview. Dr. Rosenbaum, anxiety is one of the most challenging and disturbing disorders among different age ranges, with or without pandemic, with the overwhelmed stress at this period of time. I would appreciate it if you kindly shed some more lights on this very common disorder, the incidence, symptoms, etiology, and treatments.
Well, I'm happy to talk about anxiety. It's a complicated topic. It's because anxiety, on the one hand, is ubiquitous, meaning that it's a universal human experience. It can exist as a state that people experience over time. It can be a symptom. It can be an outcome of stress or a crisis. It can also be a disorder, a psychiatric disorder. And so when we say anxiety in psychiatry, we're really not talking about one thing. I mean, it can be a transient symptom. It can be a lifelong disabling challenge. So it's pleomorphic, meaning it exists in many different forms. Everybody's had some experience of it at some point in their life. So what do we mean when we talk about an anxiety disorder? When is anxiety pathologic? And the answer to that is not when anybody experiences anxiety, because anxiety not only is normal and universal, but at times it can even be helpful and productive. So the anxiety that motivates you to perform, if you talk to athletes before a game, you might say they're anxious. I'll tell you a little story about when I was a young physician giving my first CME, first continuing medical education talk ever. It just so happened that one of my colleagues was interested in studying performance anxiety, which is another form of anxiety, public speaking anxiety. And so I was hooked up to a catheter and he was drawing blood, measuring my catecholamines, norepinephrine and epinephrine. At the same time, he was doing it with other speakers, including a very old and experienced professor who had given many such talks. And what was interesting is that in both cases, you saw the catecholamines rise, surge in the beginning, level off, and then slowly come down. So we're both experiencing the same physiology, but he felt he was being juiced and ready for a performance, like an athlete ready to jump into the water. And I felt anxious. So it was the same physiology, but with a different interpretation. So that tells you that anxiety can be normal, and a lot of it has to do with how it's interpreted. So it's pathological. Anxiety is pathological when it's chronic. In other words, when it's always there and unremitting. When it's severe, when it's really, really distressing. When it's impairing, meaning that rather than getting you ready to perform and boosting your performance, it actually leads you to underperform or even be unable to perform. We sometimes talk about something called the inverted U-shaped curve, which means that as the level of anxiety rises, it may be a motivation to perform, but then as it reaches a certain point of intensity, that it no longer enhances, and as it gets worse, you start to underperform and become more disabled. So if the anxiety impairs you, it's pathological. When the anxiety is associated with maladaptive behaviors, and with anxiety, those behaviors typically are in the general category of avoidance. So it can be so severe as with a panic attack that you flee, you actually leave the place you're in because of it, or you won't show up, you avoid, you won't go back. The agoraphobics won't go into supermarkets or any places of restricted escape like tunnels and airplanes or elevators. If it's associated with avoidance or maladaptive behavior, we think of that as pathological. People who experience lots of anxiety, who have anxiety from, that's chronic and severe, also have a variety of health-related changes. It's associated with a shortened lifespan and with increased risk of a variety of diseases like cardiac diseases. And with other psychiatric disorders like depression, it's associated with inflammation, which means activation of your immune system, which is what you see when people are under stress. And sometimes anxiety is caused by stress, and sometimes it's spontaneous. It's highly genetic in that people are born with a greater or lesser vulnerability to anxiety. When I was a researcher and early in my career, one of the areas of study was of very young children, as young as 2 years old, of parents with psychiatric disorders like panic disorder and agoraphobia, depression, and then parents who had no psychiatric disorders. And what was apparent was that significant number of those children were born with a temperamental profile that predisposed to anxiety. It was a temperament that was well described by a Harvard psychologist named Jerome Kagan, who many years studied temperament in young children. And these children, were more distressed by stimuli, really from late in utero to early infancy. And then as toddlers, they were typically fearful and avoidant of novelty and strangers, and then when they were older, more uncomfortable in the first days of school. So you could see the emergence in a significant minority of the population of vulnerability to anxiety. And that profile, called behavioral inhibition, is highly genetically predisposed. Now, when you look at anxiety, whether as a symptom or as a disorder, you have to appreciate that it presents in three important domains. The first, and those are cognitive, physiological, and behavioral. So if we start with cognitive, the way you think when you're anxious has changed. So we think of anxiety and cognition in terms of fearful cognitions, worry, expectations of bad outcomes. People with anxiety do a lot of what if this happens to me, what if I have this response. But worry is, and fearful, exaggerated fear is the most common form of cognition. Secondly is physiological. As we talked about earlier, you have uncomfortable physical activation. Again, not everybody has all of these things, but you can have rapid heartbeat, you'd be sweating, tremulousness, rapid blinking, and a variety of physiological phenomena. Shortness of breath can occur as physiological components of anxiety. And lastly, as I alluded to, is behavioral, that anxiety tends to make you quiet, to withdraw, and avoid. So cognitive, physiologic, and behavioral domains are the three domains that anxiety symptoms occur in, either as a symptom or as a disorder. And what's interesting is that any one of those three components can be targets of treatment, whether they're psychological or behavioral treatments. The most common treatment for anxiety is something called cognitive behavioral therapy, where you work with patients to help them evaluate their thoughts and make assessments of their fears and worries and to determine whether they're realistic and consider alternatives. So you can change how people think, you change your anxious thoughts. So cognitive therapy or cognitive behavioral therapy. You can treat the physiology of anxiety. You can use calming treatments like even beta blockers that reduce your heart rate and tremulousness and so forth. And behavioral treatments, are mainly involved with helping your brain learn not to fear, which is mainly exposure. So if your anxiety is associated with a phobia or certain places or situations, turns out the best treatment is to actually override your fear, go into those situations in a graduated way, from the, starting with the most tolerable and least feared, and spending time in those situations. Your brain is a learning organ, and it learns that your fears are not realized. Eventually, you learn extinction, which means you learn that your worst fears, won't be realized, and gradually your fearfulness will subside. Maybe not completely, but it will be reduced. And so you have to keep practicing extinction or exposure in this case. There also are medicines, and we can talk more about those later, but there are medications that are used either to manage the intensity or eliminate the symptoms of anxiety, or in the form of certain psychiatric disorders to treat them more comprehensively or prevent them. And I'll talk more about that in a minute. When we talk about anxiety disorders, we take those different symptoms, the cognitive, physiological, and behavioral ones, and recognize that they sometimes cluster into different categories. So the most common, for example, in children, is separation anxiety, where the child fears leaving behind their parents or going to school or so forth. And very common in the human population are specific phobias, which, depending on whether you're in a situation where you'll frequently encounter your phobic object. I mean, if you have a fear of snakes and you live in New York, it probably won't interfere with you very much. If you live in the suburbs and you have a fear of dogs, it may limit your ability to go out of doors. But people have a variety of fears that as is commonly known, whether it be, heights or insects or spiders, or the most disabling of phobic disorders is something called social anxiety disorder, which afflicts a significant minority of individuals, maybe as common as 3 to 5% of people who fear being in places where with other people, where they fear being looked at or even observed. They fear scrutiny by others. They get anxious, fear humiliation when they're with other folks, and that's called social anxiety disorder. It's very common. It leads to a number of complications because often people try to self-medicate. I think it's one of the reasons why using alcohol is common when people come together in social settings, because it diminishes a little bit the social anxiety that is pretty common. But some people have it so severe they won't venture into any situation where they'll be seen by others. The anxiety I talked about in the very beginning, public speaking anxiety, is a very specific type of social anxiety where, again, the fear is being embarrassed or doing something embarrassing, or fearing being humiliated. The British comedian John Cleese once said that it was the goal of every British citizen to get safely in their grave and while avoiding humiliation. So humiliation is a common fear, but it reaches a level of intensity for those with social anxiety disorder, sometimes called social phobia, that people really can't live a normal life, can't work, can't socialize. Sometimes anxiety occurs in a dramatic and sudden picture where a person is feeling otherwise okay, and suddenly they realize that something terrible is happening. Their heart is racing, they can't catch their breath, they feel like they're going to suffocate, they feel like they're having a heart attack or going to die, and they feel they may tremble and shake, and that that experience may emerge in a course of seconds. And that experience is called a panic attack. And that's a unique form of anxiety that, again, occurs dramatically, is associated with a feeling that one is dying or losing one's mind. It tends to be a brief experience, rarely lasts more than a few minutes or several minutes, sometimes even seconds, but usually minutes, and then passes. But because of the dramatic nature of the attack, people remain in a state of heightened alert for a while afterwards. And although they're not still having the panic symptoms, they may still be quite anxious and may feel like their panic attack lasted a long time. But usually it's more generalized anxiety afterwards. And those panic attacks can occur in people who have a condition called panic disorder, and the first attack may signal the onset of that, which is recurrence of these attacks in usually spontaneous and unexpected ways. But over time, they tend to be focused on places of restricted escape, where somebody feels they may have a panic attack and can't flee to safety. And so those places of restricted escape could be elevators, driving through tunnels, over bridges, in supermarkets, in a dentist chair, in a variety of places where escape would be difficult in the event that a panic attack occurred. So agoraphobia is the term for all those kinds of fears of places of difficulty in escaping. And agoraphobia often follows panic disorder. But agoraphobia can also occur as a form of phobia, sometimes without a clear history of panic disorder. Panic attacks can occur with other conditions. Sometimes people with depression have panic attacks, or people with bipolar illness have panic attacks. And sometimes agoraphobia can occur without a history of panic attacks. The most common form of anxiety, or the one people talk about the most, is so-called generalized anxiety disorder, which is a persisting state of heightened anxiety, of worry about any number of conditions, heightened physiologic tone, feeling on edge, maybe have tremulousness and sweatiness, or feeling more physiologically anxious. And that is one that occurs really every day, day in, day out, weeks on a time, really for as long, for 6 months or more. And that's generalized anxiety. Those are people who are just nervous all the time, and call that generalized anxiety disorder. Some of those people have been really nervous from the day they were born. And sometimes the psychotherapy, the anti-anxiety therapies like cognitive behavior therapy can help people with their worries, help people learn to feel comfortable with their physical situations, and so forth. So that's sort of an overview of anxiety, the symptom, anxiety, the experience, and anxiety disorders. And I mentioned already psychotherapies. If people's life situations or psychological issues are driving their anxiety, various forms of psychotherapy can help, but cognitive behavioral therapy is the most specific. In terms of medications, there are just so many medications that get used in helping people manage their anxiety. It might be easier to list those that never work as opposed to those that do work. And there's still a tremendous need for medicines that can treat anxiety. They're not associated with downsides like side effects or long-term risks. That, for an anti-anxiety medicine that doesn't cause sleepiness or so forth, or withdrawal upon stopping or so forth. A lot of the same medicines that are used for other psychiatric disorders, like the antidepressants, SSRIs and other antidepressants, are used for people who have chronic anxiety. They're not useful, as rapid, as needed treatments when you suddenly feel anxious. That's the provenance of medicines that are truly the specific anti-anxiety medicines, like the benzodiazepines, the Valium-type drugs, lorazepam, diazepam, oxazepam, alprazolam. Those are drugs that treat anxiety. If you have a sudden onset of anxiety, you're in a situation, you're uncomfortably anxious, or you're having trouble falling asleep because of anxiety. They work fairly rapidly within, minutes, 15 minutes to 30 minutes. And they work for a period of time. And then depending on the drug, they stop working for 2 or 3 hours, up to 4 to 6 hours for some. Those medicines are used by some people with lifelong anxiety in a daily basis, an ongoing way. And many patients find them really very helpful and help them live a more normal life. Their downsides is that they for some people, they can make them tired. They can be overused, and people can increase their dose to the extent that they have to cut back, and cutting back sometimes makes anxiety worse. If they're stopped suddenly, people can have what's called rebound or worsened anxiety, or even withdrawal. And they're frequently diverted or used by people who are overusing or abusing other substances like alcohol or opiates. And when they're combined with other medicines of abuse like alcohol or opiates, they become dangerous. Last year in the United States, there were 90 million prescriptions for benzodiazepines, which gives you some indication of how prevalent anxiety distress is. And as I mentioned, they're really the only class of medicine that are useful on an as-needed basis, to take one to help you diminish your anxiety in a particular circumstance. So one of the questions is, why do we have anxiety disorders? We assume that, our brains evolved to benefit us. So what is it, why do we have anxiety? Some have speculated that, in a large population, it's good to have some people who are anxious and some people who are fearless, that we need in a community those people who are sentinels and worry, and others who are fearless and defend and hunt and so forth. That may be one reason that, anxiety symptoms have persisted. We understand anxiety as, in a way, like we do many other medical and psychological conditions, that it's a normal function that, for whatever reason, gets dysregulated, that is not maintained at the level we need for healthy functioning, but that anxiety is hardwired in our fear circuitry, the same systems in the brain involving prefrontal cortex, the amygdala, the hippocampus, and outflows through the thalamus to other systems in the body that prepare us for threat. So it's the fear system that activates when you're in danger. If you do see a snake, or if your life's in danger, and it prepares you to avoid, prepares you to activate your body with increased heart rate and rapid breathing. It's a response that presumably would be useful for survival if there were a threat. The problem is that it's occurring when there is either no threat or something that isn't really a threat to us. So it's a normal system, the fear circuitry, that's meant to protect us from threat, that's happening when it really shouldn't. I've sometimes talked about this as an analogy to our immune system. About autoimmune disorders like arthritis and other inflammatory conditions, where the immune system, autoimmune disorders, where our immune system attacks ourself. The immune system is designed to protect us from threat from, bacteria and viruses and other, biological threats. But some cases, the immune system activates and targets, our GI tract. In the case of inflammatory bowel disease, it attacks our cells. So in this sense, you can think of anxiety disorders like in the same way we think of autoimmune disorders, that it's a system that's meant to protect us, but then activates excessively, inappropriately, or is stimulated by the wrong target, and that we need to suppress it. With immune disorders, we might use a medicine like prednisone. It's a steroid anti-inflammatory that dulls the response, but it has all these consequences and costs if we were to take it for a long time. In some ways, benzodiazepines are like that. They suppress the response, but may have consequences over time that are that make it a, Hobson's choice, meaning it's a choice with adverse consequences. So most people would say that it's important to start with cognitive behavioral therapies, that really is that non-pharmacological approaches are ideal if one can find, well-trained therapists and if those treatments work for you. But for many people, it's hard to find that therapy, and it's even with it still leaves room for improvement. I would emphasize again something I said before, that if anxiety starts to cause people to avoid things, paradoxically, the treatment is forcing yourself into those situations and staying in them, because you can take advantage of the brain's ability to learn extinction. Now, as with all psychiatric symptoms, anxiety is not a thing by itself. It co-occurs with everything else. I mean, you have anxiety with substance use disorders, you have anxiety with eating disorders, anxiety with obsessive compulsive disorders. Anxiety occurs in 90% of people with depression. Anxiety can occur with bipolar illness and psychotic disorders like schizophrenia. So anxiety is very common, but most often is not occurring by itself. In fact, a single panic attack is more predictive of the possibility of a future depression than it is even of a panic disorder. Anxiety is a risk factor, as I mentioned, for substance use disorders like alcohol. And a colleague of mine many years ago coined the term of self-medication hypothesis. That many people start drinking, in fact, as an attempt to manage anxiety. There are many things people can do to diminish their risk for developing anxiety and to help themselves overcome it. I mentioned exposure, trying to endure the situations that you avoid, and just to calmly try to float through them and be in them until your brain can learn it's not threatening. But you can increase resilience, which is the ability to adapt and overcome, through a variety of techniques and practices that are available to everyone. One, of course, is simple meditation or mindfulness, where one can learn to sit for, say, 20 or 30 minutes a day and try to clear one's mind, just focus on one's breathing, just watch oneself breathe in and out, and let whatever comes into mind pass. Don't engage with thoughts, don't get distressed by them, just sit calmly and try to think of nothing. And that's difficult to do. But if one then focuses on breathing, that can be helpful. Another technique that's enormously helpful for depression and anxiety is exercise. And that may involve a minimum of 30 minutes a day, depending on one's capacity and to manage exercise. But 30 minutes of relatively vigorous exercise, which can be a vigorous walk or something more traditional, like exercising, running on a treadmill or a stationary bike, or lifting weights, or whatever form of swimming or whatever form of exercise is accessible to you. Just exercising half hour or more a day will cut the level of anxious distress. Eating a non-inflammatory diet is also helpful. And I mentioned, the immune system and inflammation. So there are diets that are better for you. The so-called Mediterranean diet, which has low in processed carbohydrates, low in red meat, high in vegetable and fruit and complex carbohydrates, and fish is actually helpful to one's physiology and may make a difference in how one suffers or not. There are lots of treatments that are still, I think the treatment developers are aware that anxiety is a unsatisfied area of where new treatments are necessary, and there are companies pursuing anti-anxiety medications as a treatment development. So that, in a nutshell, is kind of an overview of anxiety disorders, anxiety treatments. I guess the other thing I should mention, I mentioned genetics, but I didn't mention that early developmental experience plays a role as well. So while people who are genetically vulnerable may or may not develop anxiety disorders, they're just more likely to. One's experience early in life plays a role. So if you've not been nurtured, if you've not been supported, if you've not been comforted when distressed, if you've had poverty of emotional development, meaning people didn't attend to your needs or comfort you, or you weren't held as a child, or what have you. The brain is learning intensively. The brain, I said, the brain is a learning organ, but it's a particularly active learning organ when you're young, as a child, and so it's preparing you in a way for the world ahead. And so if you've been exposed to violence, if you've been abused, if you've been emotionally abandoned, your brain is preparing you for a world where that's the norm. And so it's the mechanisms that underpin stress, which are importantly wired to fear circuitry, are creating a set point that has you more vulnerable to stress and distress, more reactive to it, more activation of your stress response and an immune response. So early childhood development does play a role, interacting with genetic vulnerability to enhance or mitigate the ultimate risk you have of developing an anxiety disorder.
Fabulous information, Dr. Rosenbaum. I greatly appreciate. Is there any medication-induced anxiety?
So can medication trigger anxiety? Is that the question?
Yes.
And really, so medications can trigger anxiety. There is a phenomenon in people vulnerable to anxiety called anxiety sensitivity, which is an excessive cognitive response to bodily symptoms. And some people have more anxiety sensitivity to others. So when a medication is activating, causes physical symptoms, causes you to tremble or causes your heart rate to increase, for some people that actually will activate anxiety. People who have anxiety, some medications trigger or make the anxiety worse. It's sometimes paradoxical, but when we start people on antidepressants, a minority, maybe 1 in 10, maybe 1 in 8, will actually have their anxiety triggered. There are other medications that create agitation or anxiety that can trigger off an anxiety-like state, and but mostly it's that there are some medications that generate physiological symptoms that feel like anxiety, but it's unlikely that a medication will turn on an anxiety disorder. It just creates some symptoms that are reminiscent of anxiety.
How is the role of insomnia?
So sleep disorders and anxiety kind of go hand in hand. And while insomnia is a feature of many psychiatric symptoms and can also be sleep disorders can occur by themselves, people with anxiety frequently have difficulty falling asleep, are easily aroused, and so don't sleep well through the night. And the coexistence of early insomnia is really a common feature of anxiety and depressive disorders. Tends to get better if the symptoms are better, and is often a target of treatment itself. So some of the same medicines that we mentioned for treating anxiety also are used to help people fall asleep and stay asleep, like the benzodiazepines or similar classes of drugs, like the so-called Z drugs, zolpidem, moranbine, zolpicone, not only help people fall asleep, but also diminish, in the same way benzodiazepines do, diminish anxious symptoms. So sleep dysfunction and anxiety symptoms tend to go together, anxious arousal. There's even a phenomenon called a sleep anxiety disorder, where people are so anxious about falling asleep, they have what's called sleep phobia, where they are so fearful of not falling asleep that it actually interferes with their ability to fall asleep. And the main treatment for that is, again, a cognitive behavioral therapy for insomnia, which actually one can find online. There are internet-based psychotherapies for sleep anxiety disorders that help you manage those symptoms. But in general, if you exercise during the day and you do good sleep hygiene, you make sure that you're not, reading your devices in bed, so you're not getting the light that's telling your brain that it's not bedtime, that you maintain good sleep dark cycles, that you don't exercise before bedtime, you limit your coffee intake to early in the day, and that you make your bed a place where you sleep. Those are all things that are helpful. But even then, some people become so activated with their anxiety about falling asleep that paradoxically it interferes. And as we talked about behavioral or cognitive behavior therapy for anxiety, there's a particular one that helps people with their worries about falling asleep. And you can go online and look at cognitive behavior therapy for sleep disorders, and there are a couple of apps that you can connect to that can manage sleep phobia.
Wonderful. For me, myself, dental procedures are one of the most important triggers to feel anxious, while we all know that anxiety is your body's natural response to different circumstances. So if it lasts more than 6 months, it would fit into the category of GAD, generalized anxiety disorder. And the other point that I got is that rebound may happen when you are under medication for treatment of anxiety. And the best treatment, it seems, that is having a very skillful therapist and cognitive behavioral therapy and exposure rather than avoidance.
Those would be the mainstays. You're exactly right about the first principles of treatment. That those are the things you try first, but just as we might use prednisone in somebody who had polymyalgia rheumatica, it gives them their life back. At some point, you say, okay, something else isn't available or working. We will use these treatments and we will manage them well so that people don't run into the complications of withdrawal or rebound. When it comes time to stop them, we do it very gradually so that they don't experience that worsening that can occur at that point.
Phenomenal talk, as always, and I truly appreciate it, and thank you so much, and looking forward for your other meetings and talks. Again, so many thanks.
Nagar, it's good to see you again, and thank you for the opportunity to speak to your audience.
Thank you so much. Have a wonderful day. ممنون که همراه ما هستید با برنامه طلوع از کانال 1 تلویزیون جهانی کانال 1. برنامه ما هر سه شنبه ساعت 6 بعد از ظهر به وقت غرب آمریکا که مطابق با 5:30 بامداد در ایران هست پخش میشه و ما جدیدترین اطلاعات پزشکی رو با بهترین های دنیا با شما در میون میذاریم. ما حتما ترجمه این برنامه رو خدمتتون تقدیم خواهیم کرد و تا برنامه بعدی روز و روزگار خوش.